Welcome to OncoPharm. I'm your host, John Bazar. I'm a professor of pharmacy practice at ETSU's Bill Gatton College of Pharmacy, and we are sponsored by Kelly C. PharmD, an oncology education company for pharmacists. Today we are talking about one of the side effects of immune checkpoint inhibitors, which is type 1 diabetes. Did a little bit of a deep dive on this recently, and this is also going to serve as a little bit of an illustration, I guess, of pharmacovigilance, of how, a new drug, in this case a new drug class or a novel drug class that's been out for, about 15 years in the immunotherapy era, 16 years, and how we learn with, and how we become confident that these side effects happen and how often they happen and how we manage those and how that information kind of gets out to everybody. So, if you go to like the pembrolizumab package insert, you will see, they talk about type 1 diabetes, and I think it says there are like 6 cases reported or something like that, and I don't know if it's pembrolizumab or nivolumab, and that's, they can only talk about what they know from that drug company. And there are case reports and things like that. So we'll kind of go through the literature, some of the high points of the literature as things go by. And so the idea here is we know that immune checkpoint inhibitors unleash the power of the immune system to attack the cancer, but as a side effect of that, sometimes the immune system attacks self. The common mnemonic of some of the more common toxicities are the legs mnemonic, so liver, endocrine, GI, and skin, with the endocrine usually being hypothyroidism or adrenal insufficiency, but can also include autoimmune attack of the beta islet cells in the pancreas, which is how type 1 diabetes happens in kids, what we call pediabetes. All right, so let's look at first a publication by Akturk and colleagues in Diabetes Medicine in 2019. This is a systematic review and meta-analysis, but it's really a review of a whole bunch of case reports and case series, 71 cases total. And they are talking about, they find, when they look at all this, 71 cases across 50-some studies, 50-some publications, case reports, I won't call it a study, that the median time to onset of type 1 diabetes was 49 days, and 76% of those folks had DKA. And about half had a positive antibody against a beta islet cell, and all of them required lifelong insulin therapy. Okay. Now, what we know from this report is we know an N. We know a number of people. We have a numerator of patients who had immune checkpoint inhibitor. Now, you could make a guess as to what the denominator would be in that population, but it would be a guess. And this happens pretty early on with rare side effects. I'm saying side effects less than 1%. We don't know how common it is. We don't have an incidence. We only have a numerator. We don't have a denominator. And this is true for, if you look in the FDA Adverse Events Database or the FAERS database, we have an N, we have a numerator, we have a number of cases, but it becomes really hard to define or describe the incidence and how common it is. Now, in this Akturk report, we do see some commonality here. We see that 3/4 of folks presented with DKA, and most presented, the median time to onset was 49 days, and they have a 95% confidence interval, and it was pretty tight. Most of these folks did present early. Now, there could be some publication bias there. Maybe not everyone is reported there. They can only review what is published in the literature. Before we go on, I should mention that a lot of listeners tune into this pod because they're new to oncology, they're trying to get up to speed, or they appreciate quick weekly updates to help keep pace with the onslaught of new information in oncology, or deep dives in some of the literature, supportive care literature like we're doing now. Well, if this sounds like you, check out the Oncology Insights newsletter, a free weekly email written by fellow OncoPharm Kelly Carlstrom, founder of Kelly C. PharmD and the ELO Collaborative Program. Each week she shares shares practical pearls, ways to think through oncology concepts without just memorizing guidelines, and insights on staying motivated and growing in your practice. It's written by a pharmacist for pharmacists, and it's easy to read. You can sign up using the link in the show notes. All right, the next publication I'm going to focus on was a little bit more recent. That one was 2019. Just a review of case reports. So Ruiz Estevez and colleagues published in JAMA Oncology in 2024 an analysis of 14,000 patients, more than 14,000 patients at Mass General in Boston. And they find a type 1 incidence, an incidence of type 1 diabetes of 0.45%. I want you to remember 0.45%. They identified a couple risk factors. One was getting combination immune checkpoint inhibitors, so PD-L1 or PD-L1 plus a CTLA-4 inhibitor like ipilimumab, if you had pre-existing type 2 diabetes, or if you had melanoma. And let's say what the odds ratios are here. The odds ratio for combination treatment was 2.57. The odds ratio for type 2 diabetes was 5.91, and for melanoma was 4.02. And my guess is, this is a theory, that the melanoma is probably linked to the combination therapy because we tend to use combination ipi-nivo more in the melanoma patient population than in other populations, right? Certainly we don't necessarily do that, a ton in like HCC, for example, hepatocellular carcinoma, all the time. All these patients had, or they looked at patients who had a low C-peptide. So C-peptide is this part of endogenous insulin that's cleaved. So if you want to see is someone making their own insulin, they should have they should have C-peptide circulating because it's cut off of normal insulin. You wouldn't just measure an insulin level because then you can't differentiate endogenous from exogenous insulin. But a C-peptide should be there. This is kind of how you diagnose a type 1 diabetic, someone with type 1 diabetes. They don't have a C-peptide. So these folks, they have a low C-peptide, and then it goes away because the beta islet cell destruction takes some time. And in this report from Weiss and Estevez, they actually had C-peptide levels in a handful of these patients, and in 11 of them, they had a follow-up C-peptide. In all 11 patients, the subsequent C-peptide level was undetectable. Right? This suggests this is irreversible, and that fits with the prior study that all these folks needed long-term insulin afterwards. They also described almost a phenotype of this. So they looked at, most of these folks had no activity in the beta islet cells, as indicated by a low or absent C-peptide level. Some of these folks had positive antibodies, autoantibodies against beta islet cells, and some didn't. So we classify these folks in two groups, no beta islet cell activity, positive antibodies, negative antibodies. Those folks who had circulating antibodies were more likely to present earlier in their time after immune checkpoint inhibitor, and they were more likely to have a very fulminant presentation, so presenting with diabetic ketoacidosis. The folks who were antibody positive presented later. And this makes you think, so the median time to presentation of type 1 diabetes if you were antibody positive was 59 days compared to 165 days if the median in those folks who had antibody negative disease. So the folks that develop type 1 diabetes on an immune checkpoint inhibitor, beyond cycle 2 or 3, it seems to be maybe a different etiology. Either it is a different type of autoantibody that we're not testing for or that we know to test for, or it's T-cell mediated attack and it's not actually antibody directed. It's direct cellular cytotoxicity, sort of how we think of cytotoxic T-cells killing cancer cells, okay? Which I think both maybe are plausible. The report goes on that for the most part, if they, especially these later, these antibody negative folks presenting later in the disease course, where they still have some preserved beta islet cell function, it's all gone within 3 months, usually, okay? The last report is from Famitani and colleagues, published in the Journal of Diabetes Investigation in 2025. So this is the most recent big one we have. Now this is in Japan, where they looked at an administrative claims database, more than 21,000 patients. The type 1 diabetes insulin after immune checkpoint inhibitor was 0.48%. The number I told you to remember was 0.45%. This is 0.48%. Really, really darn close to 0.45. And in Japan, not in Boston, they found that combination treatment with a PD-L1 or PD-L1 inhibitor and a CTLA-4 inhibitor, that combination was a risk factor. That odds ratio was 2.36. Prior diabetes was also a risk factor. The odds ratio was 1.59, not quite as strong of a risk as in the Boston study. So we have these two large thousands of patients coming up with basically the exact same numbers, 0.4 to 0.45 to 0.48%. So this is like 1 in 225, something like that, patients developing type 1 diabetes after immune checkpoint inhibitor. This is we're starting to see some similarities in the literature that, all right, I think we have a good idea of what this incidence is. It might be a little bit less than 0.45%, a little bit more than 0.48%. Maybe there are some other risk factors, but we are seeing this evidence be duplicated and repeated. And that is one of the hallmarks of good science, is the reproducibility of the experiment. And this is just describing what's out there, but we're seeing that here. The other things that we saw in this study in Japan is that type 1 diabetes following immune checkpoint inhibitor, so this drug reaction, was associated with decreased mortality. It was associated with benefit against their cancer, as was drug-induced adrenal insufficiency and hypothyroidism. This, there's a long history of this in oncology. If you had a rash with erlotinib 20 years ago, you tended to do better for your metastatic non-small cell lung cancer in an unenriched population for EGFR mutation than folks who didn't. And we've seen this with like hypertension with bevacizumab. We know that if you're having the side effect of the drug, it's probably a good thing for what the drug is going to do for the cancer. If you go to our the immune checkpoint inhibitor guidelines, you want to check a C, like our favorite guidelines, you want to check a C-peptide, verify that it is a lack of insulin production, of endogenous insulin production, and then you get them to see the endocrinology folks. They get put on insulin. If they present with DKA, you put them in the hospital, treat their DKA. You, of course, don't give the immune checkpoint inhibitor while they're going through DKA, but they already got their Pembra or their Nivo. It's in there. They're getting it, every couple weeks, every 2 to 3 to 4 to 6 weeks. So you're not changing a whole lot there. It is recommended not to try to treat steroids. There's not evidence that giving steroids can preserve beta islet cell function. It really seems that once it starts to go, it's gone. Kind of like what happens with PD-BDs in kids with type 1 diabetes. And then once they recover from their DKA, or if they don't have DKA, you continue their immune checkpoint inhibitor as long as their disease is benefiting. And then you got to work with the endocrinology folks, because the other thing you got to consider, I think, is if they already had one immune-related adverse event, maybe they'll develop hypothyroidism, adrenal insufficiency. You can just supplement levothyroxine, hydrocortisone. That's fine. But if they develop myocarditis or hepatitis, you got to use high-dose steroids, and you can tip these folks over into DKA, perhaps for the second time. So it is something to be aware of. If you go to your cancer center and you look at, have you given more than 300 doses of an immune checkpoint inhibitor? My guess is you probably have in the last couple of years, which means you're going to find some of these type 1 diabetes that are drug-induced from their Pembro, Nivo, etc. So that is what I have for you this week. Thank you for listening. You can follow me on X at PharmDeetnip and follow the podcast on various social media platforms at OncoPharmPod. And until I talk to you again, remember, doses matter.